Welcome, everyone. Today we're diving deep into something really central in radiation oncology, the late effects of radiation on normal tissues.
That's right.
We're not talking about the acute stuff patients feel during treatment. This is about the complications that can show up months, even years later.
And these can be significant, often irreversible. They pose real
Big
challenges.
challenges for patients, absolutely.
So for this deep dive, we're really going to zero in on two areas:
hmm
the central nervous system, the brain and spinal cord, and the lungs.
Okay, good focus. Because understanding what happens, the biology, the timing, how it looks clinically, that's vital.
It really is. Whether you're planning treatments day to day, managing long-term follow-up, or, frankly, studying for boards, this is need-to-know stuff.
Exactly. Our mission here is to guide you through the key insights. So let's start with the central nervous system, the CNS.
Okay.
I remember the older view was, the CNS is pretty tough, radio-resistant.
Right, that was the thinking for a long time. And it's true for acute neuron killing at conventional doses. Mature neurons are relatively resistant acutely.
Ah.
But the late effects paint a completely different picture. It turns out the supporting cells and the vasculature are much more vulnerable.
So it's the supporting cast that's the weak link for late effects.
Exactly. It's their damage that drives these often devastating late problems. When we talk about late CNS injury from radiation, we're really looking at two main cellular targets.
Okay, who are the key players here?
First up, the oligodendrocytes.
The myelin producers.
Precisely. They make and maintain the myelin sheath, the insulation around nerve axons. So damage to them or their precursors, these O2A progenitor cells, leads to demyelination,
Right.
loss of insulation.
Right, okay, like a frayed electrical wire. The signal gets messed up.
That's a great analogy. And the second major target, the vascular endothelium.
The lining of the blood vessels.
Yes, the cells lining all those tiny blood vessels in the brain and spinal cord. Radiation can really damage this delicate lining.
And what does that lead to?
It leads to things like increased permeability, leaky vessels, the formation of these abnormal little blood vessels called telangiectasias, blood clots, thrombosis, and ultimately reduced blood flow, which is ischemia.
So it sounds like it's probably not just one thing, but maybe this complex interaction between the myelin damage and the blood vessel damage that causes the problems we see down the line.
That's almost certainly the case. It's an interplay. And what's really interesting clinically is how this damage manifests differently depending on the timing.
Right.
We usually split CNS injury into early delayed and late delayed effects. That timing is a really crucial clinical point.
Okay, let's hit those early delayed ones first. You
Yeah.
said these are generally less severe and transient.
Yes, typically transient, thankfully. A classic example, especially after whole brain radiation, is somnolence syndrome.
Yeah, the drowsiness after WBRT.
Exactly. It usually pops up about, say, 4 to 8 weeks after finishing the radiation. Patients feel really drowsy, lethargic, just wiped out. Sometimes nausea, vomiting, headache, too.
Any idea what's actually causing that? The mechanism?
The leading theories point towards temporary demyelination, maybe some inflammation, or perhaps the release of certain signaling molecules, cytokines, in the brain tissue.
But the key is it usually gets better on its own.
Yes. The good news is it's typically self-limiting. Resolves within a few weeks, usually. We might give steroids if the symptoms are really bothersome, but often it just needs time.
Okay. What's another early delayed effect? You mentioned the spinal cord.
Right. After spinal cord irradiation, you can see transient radiation myelopathy. And the classic sign associated with this is Lermite's sign.
Lermite's. That's the electric shock feeling, right?
That's the one. This usually shows up a bit later than somnolence, maybe 1 to 6 months after radiation, often peaking around 2 to 4 months. And the hallmark, Lermite's sign, is that jolt, that electric shock sensation, shooting down the spine, sometimes into the arms or legs, when the patient bends their neck forward.
Wow, so just tipping your head forward causes this chlorenglising.
Exactly that dysmizing. Like the somnolence syndrome, it's thought to be caused by temporary demyelination in the irradiated part of the cord.
And this is a really important clinical pearl here.
Yes, absolutely critical. Transient radiation myelopathy, even with a dramatic Lermite sign, almost always resolves spontaneously over weeks to months. And importantly, it does not predict that the patient will later develop permanent myelopathy. It's transient.
Okay, so sticking with the frayed wire analogy for these early delayed things, the insulation, the myelin, is temporarily damaged, causing these intermittent signal problems, the drowsiness, the zaps, but the wire itself isn't permanently broken. The insulation often repairs itself.
That's a really good way to think about that transient nature. But now we need to shift gears to the late delayed effects.
Okay.
And this is where things get much more serious because these effects are typically progressive and, unfortunately, irreversible. They show up months to years after treatment.
Right. This is where we worry about things like radiation necrosis,
Right.
brain, or spinal cord.
Radiation necrosis, yes, a major concern.
Yeah.
And its onset is really variable, typically 6 months to several years post-RD, but it can even be later.
And the underlying cause, still that vascular and glial damage.
Exactly. It's complex, but involves significant vascular damage causing ischemia, reduced blood flow, plus direct damage to the glial cells, maybe even neurons. You end up with a focal area of dead tissue within the brain or cord.
And clinically, I mean, this sounds like it could easily mimic a tumor coming back.
It's often a nightmare for that reason. The symptoms, new focal deficits, seizures, signs of increased intracranial pressure if it's in the brain, can perfectly mirror tumor recurrence. If it's spinal cord necrosis, you see progressive neurological problems below that level.
So how do you tell the difference? On imaging, I imagine it's tough.
Very tough. On MRI, necrosis often appears as an enhancing lesion with surrounding swelling or edema. Looks just like tumor growth. This is a classic clinical decision-making problem.
So what do you do?
You often need more advanced imaging, like PET scans or MR spectroscopy, to look at metabolic activity. Sometimes you even need a biopsy to be sure.
And this is highly dose dependent, I assume.
Extremely dose dependent. We talk about the TD55, the dose at which 5% of patients might develop necrosis at 5 years. For the whole brain with standard fractionation, that's around 45 to 50 gray. For SRS, stereotactic radiosurgery, single doses over, say, 12 to 15 gray to even small volumes carry a significant risk.
And the spinal cord?
Similar TD55, around 45 to 50 grays with conventional fractionation. But, and this is crucial, the spinal cord is very sensitive to high doses per fraction. That's why we have such tight constraints for SBRT near the cord.
Okay. Necrosis is one major late effect. What else falls into this category?
Another important one is leukoencephalopathy.
Leuko meaning white, so white matter problem.
Exactly. This is more diffuse damage to the white matter tracts. You see demyelination again, loss of the axons themselves, and this reactive scarring process called gliosis. It's particularly associated with whole brain radiation, especially if it's combined with chemotherapy like methotrexate.
And the symptoms there are more global.
Yes, typically a picture of progressive cognitive decline, which can sadly progress to overt dementia. Patients might also develop problems with walking, gait issues, and incontinence. It's a diffuse white matter injury.
And that cognitive decline itself, even without full-blown leukoencephalopathy, is a known late effect, right? Especially after whole brain radiation.
Absolutely. Cognitive decline can range from quite subtle difficulties with memory or executive function to severe dementia. And we know certain brain regions are particularly sensitive, like the hippocampus, which is critical for memory formation. Sparing the hippocampus during WBRT is now a major focus to try and mitigate this.
Okay. And then for the spinal cord, the most feared late complication.
Is permanent radiation myelopathy.
Permanent. Irreversible.
Yes. Progressive and irreversible damage to the spinal cord. Onset is usually 6 months to 2 years after treatment, sometimes later. Patients develop progressive neurological deficits below the irradiated segment weakness, sensory loss, eventually paralysis, plus bowel and bladder dysfunction.
And the mechanism. Similar to necrosis.
It involves a combination of white matter damage demyelination, necrosis alongside that critical vascular injury component. This potential outcome is a major reason why the spinal cord is such a critical dose-limiting structure in so many treatments.
Wow. Okay, those are some serious late effects in the CNS: necrosis, leukoencephalopathy, cognitive decline, a permanent myelopathy, and maybe that mnemonic we talked about could help. NLCP.
NLCP, that works well. N for necrosis, L for leukoencephalopathy, C for cognitive decline, and P for permanent myelopathy.
NLCP. Good way to keep those big, irreversible late CNS toxicities straight. Useful for boards, definitely.
And for clinical practice, absolutely.
All right, let's switch gears now. Let's dive into our second critical organ system for today. The lungs.
The lungs, yes. Another major dose-limiting organ, particularly for any thoracic radiation.
And the injury pattern here is a bit different, isn't it? More phased.
It is. We typically see two main phases. There's an early-late inflammatory phase called radiation pneumonitis, and then often following that, or sometimes developing later on its own, is a very late fibrotic phase, pulmonary fibrosis.
So, like the CNS, are there specific cells in the lung that are the key targets here?
Yes, the cell type most often implicated as the primary target is the type 2 pneumocyte.
Type 2 pneumocyte. Okay, what makes them so important?
They're fascinating cells, really crucial for lung function and repair. They produce surfactant, that substance that keeps the tiny air sacs, the alveoli, from collapsing, and maybe even more importantly, they act as progenitor cells.
Meaning they can divide and replace other cells.
Exactly. They can divide and differentiate to replace the type 1 pneumocytes, which are the very thin cells that form the main surface for gas exchange. So if you damage the type 2 pneumocytes, you mess up surfactant production and the lung's ability to repair itself after injury.
Okay, that makes sense why they're critical. Any other players? Endothelial cells again?
Yes, similar to the CNS, damage to the endothelial cells lining the lung capillaries also plays a significant role, contributing to the inflammation and later fibrosis.
So, damage those type 2 cells, and you hit both immediate function and long-term repair. Okay, let's break down the clinical syndromes, starting with radiation pneumonitis. You called it early late.
Early late, yes. The timing is a key clinical point again. Pneumonitis typically starts anywhere from 1 to 6 months after finishing radiation,
In a peak.
often peaks around 2 to 3 months. If you look at mouse studies, it corresponds to about 14 to 24 weeks. Pathologically, what you're seeing is an acute inflammatory response in the lung tissue.
Okay, walk us through that inflammation. What's happening at the cellular level?
Well, you get damage to those sensitive type 2 pneumocytes and the endothelial cells. This makes the capillaries leaky, so fluid starts to seep into the alveolar spaces. Then, inflammatory cells, macrophages, lymphocytes, they rush into the area.
And they release chemicals?
Exactly. They release a whole cocktail of pro-inflammatory cytokines. Key ones here are TNF-alpha, IL-1, and IL-6. These molecules basically amplify the inflammatory reaction.
Okay, so inflammation, fluid, cytokines. What does the patient experience? What are the symptoms?
It's a real spectrum. Some patients might be asymptomatic, and you only pick it up on imaging. Others can develop severe, even life-threatening respiratory distress. But the common symptoms are usually a dry, non-productive cough, shortness of breath dyspnea, sometimes a low-grade fever, and maybe some chest pain.
And what does it look like on a CT scan?
Typically, you'll see hazy opacities, areas that look like ground glass, or even denser consolidation within the radiation field. It often has this classic port-shaped distribution, outlining where the beams went.
And the course. Does it get better?
It can be self-limiting and resolve. But sometimes, unfortunately, it can progress into the chronic fibrotic phase. If a patient is symptomatic with pneumonitis, the main treatment is corticosteroids.
To dampen down that inflammation.
Precisely. Steroids help control the inflammatory response and relieve symptoms.
And I assume this is dose and volume dependent too.
Oh, absolutely.
Yeah.
Strongly related to both the dose and the volume of lung irradiated. We use metrics like V20, the percentage of total lung volume getting 20 gray or more, to predict risk.
Yeah.
The TD5 for symptomatic pneumonitis, if you were to irradiate the whole lung, is somewhere around 17.5 gray. Sparing lung volume is critical.
Okay, so that's pneumonitis, the earlier inflammatory phase. Now let's talk about the later phase, pulmonary fibrosis. This sounds more permanent, more like scarring.
It is exactly that. Pulmonary fibrosis is a chronic, progressive scarring process in the lung.
And the timing.
Onset is usually later than pneumonitis, typically starting 6 to 24 months after radiotherapy. It often follows an episode of clinical pneumonitis, but, and this is important, it can also develop gradually without any obvious preceding inflammatory phase. In mouse models, this corresponds to a much later time point, around 52 weeks or more.
So what's happening pathologically here? How is it different from the acute inflammation of pneumonitis?
It shifts from acute inflammation to chronic, persistent inflammation and abnormal repair. You get ongoing cytokine signaling, and one cytokine really stands out as a key driver here, TGF-beta.
Transforming growth factor beta.
Yes, TGF-beta. It's a major profibrotic signal. It activates resident fibroblasts, causing them to transform into these cells called myofibroblasts.
And what do?
They are collagen factories. They just start churning out excessive amounts of collagen and other extracellular matrix proteins, depositing it in the lung interstitium, the tissue between the air sacs. This leads to irreversible scarring, destruction of the normal lung architecture, thickening of the alveolar walls, and worsening vascular damage.
And what does that mean for the patient clinically?
Progressive shortness of breath is the main thing, a chronic dry cough. Lung function tests show what we call a restrictive pattern. Lungs have become stiff, scarred, and can't expand properly. Gas exchange becomes increasingly difficult.
And imaging, does that look different from pneumonitis too?
Yes. Instead of the hazy opacities of pneumonitis, in fibrosis you see signs of scarring, reticular patterns like a network of lines, volume loss in the irradiated part of the lung, and sometimes traction bronchiectasis, where the airways get pulled open by the surrounding scar tissue. You might even see honeycombing in advanced cases.
And the course is generally irreversible, progressive.
Generally, yes. And like pneumonitis, the risk and severity are related to the radiation dose and volume delivered to the lung.
Let's try that mini case idea to really nail the timing difference. A clinical pearl, maybe?
Okay, sounds good.
So imagine you treated a patient for lung cancer. Standard radiation to the chest. 3 months later, they call. Dry cough, getting short of breath. You get a CT. It shows hazy opacities, pretty much contained within the radiation port. What are you thinking?
Okay, 3 months out. Cough, dyspnea, hazy opacities in the treatment field. That time frame, those symptoms, that imaging, it screams radiation pneumonitis.
Exactly. Now, same patient, same treatment. But instead, they come see you 18 months later. They've noticed gradually worsening shortness of breath over the last few months. PFTs show a restrictive pattern. CT scan shows definite volume loss in the treated area, reticular lines, maybe some traction bronchiectasis. Now, what's the likely diagnosis?
18 months out, progressive symptoms, restrictive physiology, CT showing clear scarring.
Yeah, that's pulmonary fibrosis.
Right. That timing difference, 2 to 3 months peak for pneumonitis versus 6 months plus, often much later, for fibrosis is a really key distinction. Helps guide your thinking and management.
Definitely a useful distinction for clinical decision-making. So understanding all these mechanisms, the timelines for both CNS and lung, it's fundamental. But the big challenge remains. How do we actually minimize these late effects when we're planning treatment?
Well, that brings us to clinical decision-making and management. And the first pillar is dose constraints.
Setting limits.
Absolutely. We rely heavily on established dose volume constraints for organs at risk, like the brain, the spinal cord, the lungs. These are based on clinical data and radiobiology, often guided by those TD5 values we mentioned, trying to keep the risk of these severe late effects acceptably low.
And fractionation is key too, right? You mentioned the sensitivity to dose per fraction.
Hugely important, especially for these late-responding normal tissues, CNS, lung fibrosis development. They characteristically have low alpha-beta ratios.
Okay, refresh us quickly. Low alpha-beta ratio means?
It means they're disproportionately sensitive to the size of the individual radiation dose per fraction compared to tissues with high alpha-beta ratios, like many tumors or acutely responding tissues. Giving a large dose in one go hits these late-responding tissues harder.
Which is why standard fractionation, small daily doses, is often safer for them.
Exactly. It exploits that difference in fractionation sensitivity. It's also why we have to be incredibly careful with hypofractionated regimens, like SBRT or SRS, near these critical structures. The planning has to be meticulous, the dose delivery highly conformal, and the constraints rigorously respected.
And then there's monitoring and management after treatment.
Critical. Long-term follow-up is essential to detect these late effects early. For pneumonitis, as we said, early intervention with steroids can be very effective.
But for the really late established stuff like necrosis or fibrosis,
unfortunately, our options are much more limited there. Once significant necrosis or fibrosis is established, effective treatments are few. Management often becomes supportive care, managing symptoms, which really underscores why prevention through optimal planning is paramount.
Okay, really important points. Let's switch gears slightly and put some of this knowledge to the test. Time for our board review blitz.
All right, let's do it.
4 questions, straight from the material we've covered. High-yield stuff. Ready?
Ready.
Question 1. A patient developed electric shock-like sensations down the spine and limbs upon neck flexion 3 months after undergoing cervical spine irradiation. This is most characteristic of A. Radiation-induced somnolence syndrome. B. Acute radiation myelopathy. C. Permanent radiation myelopathy. D. Transient radiation myelopathy, also known as Lermit's sign.
Okay, the key here is the specific symptom electric shock with neck flexion and the timing 3 months post-RT. That is the absolute hallmark of Lermit's sign, which characterizes transient radiation myelopathy. So the answer is D.
D. Transient radiation myelopathy, Lermit's sign. Correct. Okay, question 2. The primary cellular target widely implicated as a critical initiating event in the development of late radiation-induced pulmonary fibrosis is the A. Type 1 pneumocyte. B. Alveolar macrophage. C. Pulmonary fibroblast. D. Type 2 pneumocyte.
We discussed their crucial role in surfactant production and as progenitor cells. Damage to them kicks off the whole cascade. The answer is D, type 2 pneumocyte.
D. Type 2 pneumocyte it is. Correct. Question 3. Which of the following is considered a key cytokine driving the process of radiation-induced fibrosis in tissues like the lung? A. Interleukin 1, IL-1. B. Tumor necrosis factor alpha, TNF-alpha. C. Transforming growth factor beta, TGF-beta. D. Vascular endothelial growth factor, VEGF.
While IL-1 and TNF-alpha are important in the earlier inflammatory phase, the major driver consistently implicated in the fibrotic process, the scarring, is TGF-beta. So the answer is C.
C. Transforming growth factor beta. Correct again. Last one. Question 4. A patient develops symptomatic radiation pneumonitis. When would this most typically occur after completion of thoracic radiotherapy? A. Within 2 months. B. 2 to 3 months. C. 6 to 12 months. D. More than 2 years.
Pneumonitis is that early late effect. The typical window is 1 to 6 months, but the peak incidence is usually right around 2 to 3 months post-treatment. So the answer is B.
2 to 3 months. Perfect. Excellent run through on those high yield points.
Good questions. They hit the key concepts.
Now, just briefly touching on controversies or advances, we mentioned the difficulty in distinguishing necrosis from tumor recurrence. That remains a real clinical challenge.
It does. Requires careful evaluation, advanced imaging, sometimes biopsy. And on the treatment side, while there's ongoing research into mitigating fibrosis, maybe targeting pathways like TGF-beta,
Right.
clinically, right now, our ability to effectively treat or reverse established late effects like significant necrosis or fibrosis is unfortunately still quite limited.
Yeah. Prevention really is the best strategy here.
Absolutely. Careful planning, respecting constraints, optimal technique. That's where we make the biggest difference for these late effects.
So let's try and wrap this up. Can you recap the key takeaways from our deep dive today?
Sure. For the CNS, remember the key cellular targets are the oligodendrocytes, leading to demyelination, and the vascular endothelium. Clinically, we divide syndromes by timing. Early delayed includes somnolent syndrome and Lermit's sign, typically transient. Late delayed effects are the serious, often irreversible ones. Necrosis, leukoencephalopathy, cognitive decline, and permanent myelopathy. Remember NLCP?
NLCP, got it. And for the lungs.
Key targets: type 2 pneumocytes in the endothelium. The syndromes are radiation pneumonitis, that's the early late inflammatory phase, peaking around 2-3 months, driven by cytokines like TNF-alpha, IL-1, IL-6, and pulmonary fibrosis, the late progressive scarring, driven largely by TGF-beta, usually setting in 6 months or later.
And managing the risk involves
Strict adherence to dose volume constraints, understanding the importance of fractionation, especially the sensitivity of these low alpha-beta tissues to high dose per fraction, and diligent long-term monitoring.
excellent summary. So as we close out, here's maybe a final thought for everyone listening to mull over. Knowing what we know about these complex, sometimes devastating, and often irreversible late effects, how does that knowledge continuously shape our day-to-day decisions and treatment planning? How do we keep pushing for better tumor control, maybe through dose escalation, while staying absolutely committed to minimizing the risk of these long-term toxicities that can profoundly impact a patient's quality of life for years to come?
That is the central tension, isn't it? It drives so much research and technological development in our field. It really highlights the need for careful patient selection, individualized planning, and that crucial long-term follow-up. It's an ongoing balance.
A critical balance indeed. Well, thanks for joining us for this deep dive. Remember, you can find more resources and practice materials over at radonsmartlearn.com. Be sure to subscribe to Radon Smart Review for our next session. Thanks for tuning in.